Thanks for letting me come today, Dr. Howell, and appreciate everybody in the room that it came to hear, because this is one of the most important things that we're working on, as Dr. Howell pointed out. I'd also like to give a shout out to my student Lauren, who I have the privilege of working with this year. She's an accelerated student who has just started her work, and she is doing a great job, and I think she gave her first shot this week, so you know, that's a big deal. And I'd also like to note that we have in the room also is Jody Kepnich. Jody, would you mind standing up? Jody is a nurse who is, you're going to see later, kind of significant in the work around that we're doing currently about readmissions. So I will get started here. What I'm going to talk about is how to coordinate the efforts among the care coordinators. We're going to talk about the effectiveness of transitional care services in reducing readmissions, and of course talk about the transitional program to support our high-risk patients. These are just a little bit of an outline of what I'm going to cover, talking about our sites of care, our system of care, give you a little bit of a background, and then talk about what we're doing to identify those patients at risk for readmission and the care interventions we're putting into place. And then I thought I'd end with just a quick note, as Dr. Howell already mentioned, that this is a wonderful opportunity. This is what nurses know how to do. We've been coordinating care all of our lives, all of our nursing lives, wherever role you work in, and I think this is just becoming an exciting role for nursing. It's really actually being recognized, the role that we play. This is just to kind of, when we talk now at Allegiant Creighton, we're talking a little bit about reminding ourselves not all care is happening in the hospital. And as we look in the future, we're probably going to see more and more of what is being done in the hospital that's going to be done in other places, either an ambulatory setting or possibly at home. I remember probably 30-some years ago when I was Vice President of Nursing at Lutheran Medical Center, and I remember the year that we budgeted 10% of our surgeries were going to be outpatient. I thought, I cannot believe this, 10% of our patients. This is when we were still doing cataract surgery with sandbags, you know, for like 7 days or something. And so I think I think our outpatient surgeries now account for more than half, or at least half of what we do in hospitals. So I just kind of highlight that when we think about covering all aspects of care at Allegiant Creighton and in any health system, you have an ambulatory setting, have an acute care and post-acute. It's kind of a reminding thing for us. We just talked about this week in our ethics council. Well, do we have somebody from ambulatory care? Do we have somebody from post-acute? And do we have somebody from acute? So the focus has been on acute, but as as the whole morning is going to point out, and that is that we are transitioning care to all of these sites of care. So I just put in these percentages. These percentages reflect where Allegiant's care is in terms of revenue dollars. So 7% of our revenue is in the ambulatory setting, 53% in acute, and in post-acute 40%. And this is what we're going to start seeing to shift. Now this is fairly true for health systems nationally as well, but kind of gives you an idea of where our dollars are today, and then in time they're going to change. Now, for those of you from Allegiant Creighton that have gone to any kind of planning session, you're very familiar with this slide. This is from the SG2, which is a planning think tank healthcare company out of Chicago, and we use them for consulting around the future of care and where we're headed. So this is a system of care, and that's kind of why we talk about the acute, the post-acute, and the ambulatory care. As you can kind of see there, we kind of talk about self-care at home, community wellness fitness centers, talk about pharmacy physicians, ambulatory surgeries, then into acute care, and then into the recovery and rehabilitation in post-acute. So this is something that we've rather than kind of looking at just the hospital, we start really looking at all the systems of care. So this is a good slide for you to kind of keep and think about as you even look at where you're going to practice or what you should be knowing about. The advantages for me for being in home care for a number of years, I was in hospitals and then I was in home care for a number of years and then back in the hospital, is that it does give me an opportunity to really gives me the experience, I would just say, to really see the patient in the total. Because sometimes I remember when you're just in the hospital or just in the clinic or just in a nursing home, you tend to think of the patient just in your side of care and not that they're in all of these other sites. So it's really helpful to kind of bring that perspective. Well, Dr. Howell already covered all the key information around CMS. I'm glad our numbers matched. And so this is, and as she had already pointed out, not only was this something that became a push from CMS, but it was always also the right thing to do for our patients. So these are Allegiant Health's numbers, and it does not include Creighton at this point then we were putting this together. So their current readmission at same hospital is 8 to 9%, any hospital 11, and in the Allegiant Hospital 11 in any hospital. Now the reason is as Dr. Hall already pointed out, we don't really know because we don't have the information systems that really tell us that a patient went from Bergen Mercy and then maybe went and was admitted to the med center, and then from the med center maybe went to Methodist. We can't pull all that together. CMS knows, but by the time we get that information, you know, it could be late. So we are working with the people in the state to try to figure this out better. But this is what our current information looks like. As far as daily discharges, we have about 78 patients that are discharged every day, and about 9 of these return to a hospital within 30 days. So our challenge is to assure safe and effective transitions of care. If you ever hear Rick Hackton talk, he's our CEO of Allegiant Creighton, and he reminds us that these are not discharges. Remember that system of care, they're just transitioning. So we're trying to really think more about that this is our patient and that we will care for them throughout the whole transitions of care. So if we were to sit down and figure out now how are we going to do this, how are we going to design a real-time solution, can we identify the high-risk subset of patients, can we focus our interventions and resources at the most high-risk population? Because if you don't really know the risk, we're trying to treat, as we would, all patients to prevent hospitalizations and rehospitalizations, but we know there are some that are not at high risk for readmission, and of course how to coordinate our interdisciplinary team. So therefore, we're going to try to allow the maximum impact on the patient population at greatest risk for readmission, again aligning our resources, and that's our challenge. One of the efforts that we had was to how are we going to gather everybody around care coordination. We had probably 3 or 4 meetings trying to gather everybody at Allegiant Creighton that was doing something around care coordination. Now that's kind of hard to pull out because a lot of what we do is care coordination, but it was what initiatives of everybody working on. So we had at least a series of 3 or 4 meetings and dinners to kind of really coordinate that. And we found some really wonderful work being going on, but in some cases we didn't even know what work was going on, and we were really trying to pull it together. So then we pull it together into a decision accelerator. For us at Allegiant Creighton, that means we get into a room, we have everybody together as a group, and then we focus into 5 or 6 work areas and projects. We come back and then we share those learnings, and then we decide on what's our next step, what's our 30-day step, our 90-day. And this is a practice of planning that was brought to us a number of years ago from how high-tech companies do it. It was a practice from the Silicon Valley, and we have a facilitator who helps us with that. They bring in national experts, they bring in frontline staff, physicians, nurses, social workers, whoever needs to be there to plan and coordinate that. So that's what a decision accelerator is, and it's a really great way to, rather than meeting for months and years in a committee, you try to get everything done in one time and then go out with a plan. And of course, we looked at the data and we reviewed the literature for best practices, and then we found the article. One of the presentations at one of these care coordination evening meetings was an article that we have a PhD MD who works what we call business enterprise, business intelligence enterprise, or enterprise intelligence, I think I say that later. And he had this article, and it was about a simple tool that would help us predict risk. So what should we do that we had this great article and this great idea? Well, as we always do, we put together a committee. So this is, I can't remember who sent this at what presentation, but we love this. A committee is a group that keeps minutes and loses hours. So we were hopeful we weren't doing that, but that's exactly what we did. We got a group together and we created the LACE committee. The LACE committee then put together, of course, a charter, a sponsorship, put together membership, and our pledge was in the very beginning is this is just not going to be an academic exercise because there's so much interesting information in this and so much to do just around looking at it, analyzing it, that could be, as one of the members said, this could be a researcher's life's work is to work on this. But this was our pledge, to actually take what we were going to learn from this and put it into place. So just to give you an idea, a LACE is a very simple 4 items. Now there are a million tools out there, maybe a million's too strong, thousands now tools out there that they'll sell you for millions of dollars that will help you predict risk. Dr. Howell already mentioned that we're going to transition to the EPIC information system, which is a really one of the fastest growing and more robust integrated systems in the country, and they will probably be able to do this for this maybe eventually automatically as well. But LACE is simply the length of stay, the acute emergent, whether they've had whether their admission was emergent, comorbidity, which is the Charleston comorbidity around various chronic diseases, and then visits to the emergency in the 6 months prior. And as you can see, as the LACE score goes up, the risk for readmission is higher. Well, we were so excited when we saw this, and we thought this could be something, and we thought, what we do sometimes in operations and in health systems is, well, let's just take this LACE tool and let's just see if it works, and let's just have the nurses figure out what somebody's LACE score is, and then we'll just see if try to see if this will work for us. But what our smart people in this committee did was, let's just put it on our own data. Let's just look at all of 2011 and see if this pans out for us. Would we have the same curve? And we did. And it was so exciting. I think I remember Jody at the meeting saying, oh my God, she says she was so excited her hair was standing on end. Because no matter what we did, it matched. The LACE, we put all of the 2011 data in there, we matched. What did somebody say? Well, it's not like that at my hospital. At my hospital, we have our patients are sicker. So we put the LACE score there. Well, it wouldn't work for older people. Dr. Brenda Bergman-Evans is on our team at Allegiant Creighton, has done a lot of work in the transitions of care, and she said, well, it won't look the same for older people. It looked the same. So we were pretty confident. And then, Jody, we also ran it around various diagnoses as well, the AMI, the pneumonia, and lo and behold, it did really work. Then we had the huge discussion about, well, what is the number? What is the LACE score number that we should focus on? And so we'll talk about that. So the Enterprise Intelligence is a department within Allegiant that has really smart, highly tech people that understand data warehousing and databases, really kind of brought to us the link that we're able to take this LACE study and LACE information and make it an automatic situation by pulling out all this information. Now, in putting the LACE score into, remember, this was not going to just be an academic exercise, and putting it into data that would be available real time, they had to make some adjustments to the LACE score to make it work. We had to put some holders in there for length of stay and some changes in the comorbidity data, and therefore when we sat down and decided what score we would use, all of that went into play. We did document and note every single one of those, though, so that as we reproduce this and able to publish later, we will know exactly what we did. So why did we use LACE? I think I've already mentioned to you there are a lot of risk assessment tools out there now, but the LACE is simple. It was easy to understand. It's easy to explain. They have now gone and starting to explain this around to all of our campuses, and I think it's going pretty well, that people are understanding it and making sense. People certainly question it. Is this really going to work? But the beauty of it is that it is not something that somebody has to sit down and figure out. It is actually automatically pulled, I think, between 6 hours and 24 hours of admission that we should be able to get a LACE score, and then they will put it on, it goes directly onto some reports. So no additional intervention is needed. And then this is, give you again what the LACE score is. Now, of course, our ultimate aim here was that our high-risk patients would be identified shortly after admission. Now, how many years, maybe always, we've said in nursing when you're in the hospital that discharge planning begins on admission. We say that, I think we believe that, but sometimes it happens maybe at the last day or a couple of hours before dismissal. But this really gives us an idea to identify those high-risk patients while they're in the hospital, so that it gives us an opportunity to do not just the care interventions that have been proven to help post-discharge, but there's also some work we can do right while they're in the hospital. So to gather the team and to work on care interventions specific to prevent the readmissions while they're here. So there's a more intense focus on a smaller population. Now, part of, if we looked at our 78 dismissals every day, part of the discussion has been, well, we need to hire 60 more care coordinators. Well, me being a little bit nervous about that because I don't want any more hours or pay, or not pay, but resources being pulled because we don't want our direct care to be impacted. I'm a little stingy about other people trying to add other positions. So we thought there's got to be a better way, and how would that end up how would that impact in workforce anyway? So that's why we really found that the LACE tool provided us some sense of who we really should be watching, and of course that we want to improve transitions across the continuum, especially for this population, and we were able to get our arms around. So how do we prioritize resources? I think you can read that pretty good. So we looked at our number of discharges per day, and then we looked at the number of potentially preventable readmissions, and that was, so we decided that the LACE score of 9, watching about 19 patients closely, would probably be our best. Now, this was not easily arrived. We had quite a bit of discussion. I really wanted to go a little lower. I was a little nervous that we weren't going to grab enough people, but everyone was very convinced, and I was convinced that this was the right LACE score to go with. So that means to us now, anybody with a LACE score of 9 and above while they're in the hospital, we will put care interventions in place. And those that have 8 and below would be a normal care situation for us. So Jody and one of our quality directors developed got a team together, and they developed a readmission prevention protocol. So these protocols will be implemented for patients on a LACE score of 9 or above. It is an interdisciplinary approach to meet the unique needs of that high-risk patient, and of course they're going to use evidence-based interventions, which Dr. Howell really talked a lot about. You know, Allegiant Creighton does have some good experience in the post-discharge care, using the Coleman model, post-discharge follow-up phone calls. Our Uninet had a project with Blue Cross Blue Shield that did post-discharge calls and making sure that they were seeing their providers and making sure medications were on target. So we had some experience with that. We had also had experience with our nursing home network with nurse practitioners following patients into the into the nursing homes. So we've had some experience with this transitions of care, and this is just going to really kind of highlight more carefully the patients we should be watching more carefully. So we also know that we're going to transition. So when a doctor is, a provider is seeing a patient within a few days after discharge, which would be part of the protocol, they'll also, that LACE score will go everywhere. So we even talked yesterday when I was at home care. If they know that they have a patient with a LACE score 9 and above, then that patient really needs to have the resources, maybe be seen more quickly and more intensely than some of the other patients. And this just gives you an idea of how those scores are added up and how that works over the course of their stay. It's calculated every night for each inpatient readmission, and it's integrated into reports that are already being used by nurses, care managers, and physicians. And as I said, as our intent, of course, is to transition this to wherever. Now, this is just the operational workflow that Jody and the team worked on, as to how the patient's admitted, when it's calculated, and then the interdisciplinary team works to look at what are the key areas that they need to focus on while the patient's while they're hospitalized. I will say that, and then they review the care manager and social works reviews and uses it to assess discharge planning, and then other disciplines review daily scores for interventions. One thing we do know, just as a simple note, and that is that we do know that the LACE score is valid. Jody and team went and looked at all the LACE scores that were being populated and seeing if they were being populated, and then looked at the patient to say, yeah, that does make sense. We didn't want someone that looked like they were being noted as a LACE score of 9 or 10, and when actually they looked more of a 1 or 2. So they've done all that validations, and so they're ready now to do the care interventions. What we do know is that the LACE score itself is valid. What we're really going to study is what nursing interventions, physicians interventions, interdisciplinary interventions that we put into place will make a difference. So as far as the nursing interventions, our nurses will verify that they have a primary care physician. You know, a large number of patients don't. They looked at a study, just a brief review of all the patients that had been admitted to hospitalists. There were about 2,000, and 700 did not have a primary care physician noted in the record. So we all know that primary care physicians following patients is also improves the health care of patients and keeps them from being hospitalized in the first place, possibly, as well as being readmitted. So the daily education using TeachBack. We include family and caregivers. We explain the risk of readmission to the patient. You know, we talked about patient partnership. We're thinking, well, you should know if you're a high risk for readmission. You should know that you're a LACE score of 9 or 10. You should know that so that you can participate and be a partner in your care. And so and then the nurses would also schedule nursing proactive care discussions with the patients and families. Nurses will also address the LACE score and interventions during what we call our interdisciplinary care rounds that happen every day with our patients on their plan of care. Obtain the appropriate referrals as needed. We know a lot especially for the older adult, being up and mobile and moving is key. We're even doing that in our ICUs, moving patients that are even on vents. So there's some mobility in there. Schedule the post-discharge appointment within a couple of days with the physician, and then complete the written discharge instructions, and then ensure transfer communication is if they're going to a post-acute care, such as a skilled nursing facility, long-term care, rehab. The physician interventions is to possibly consider a higher level of care for post-discharge. We used to say everybody has the right to fail at home. That was just something we always thought in home care, give them a chance to go at home, but not anymore. We're trying to think we really can't let patients do that. It's not good for them, it's not helpful, and hospitalization is not something that we would want them to consider if they didn't do okay at home. So consider right then a higher level of care, and of course this would be in collaboration with also with nursing and with our social workers. Consult pharmacy for medication review. call the primary care physician to discuss care opportunities, and then the physician and care manager verify and agree on the placement plan. Interdisciplinary interventions, pharmacy to review their number of medications. As we know from Coleman's work, that medication management, symptom management, and seeing their primary care physician or their primary provider is key to people being successfully discharged or transitioned. So pharmacy is key to review medications, looking at therapy and support for ambulation transfers and safety considerations, and how successful they'll be at the next transition of care, and of course nutrition and dietary. The care management and social work interventions is, of course, again, that important role of finding a primary care physician, considering the higher level of care post-hospital. Consider palliative care for a referral as possible. We do want to do eventually kind of a review of, are there a certain high level of LACE scores that maybe require patients really should be having a palliative care hospice referral. Perform an enhanced assessment of post-hospital needs, explain the readmission to the patient, ensure discharge follow-up, and then assure an effective handoff. Okay, so we talked about those, remember the three levels of care. We talked about acute, we talked about ambulatory, and we talked about post-discharge. So in the acute care, what this is going to provide us is early identification, to be able to focus on the interdisciplinary interventions to alert nursing, pharmacy, and the team that this patient is at high risk. So we'll know right away who we really want to focus on. And then when we take for the acute care, goes to the ambulatory setting, the effective physician provider follow-up. Is there, what are the care opportunities for this patient that has a high LACE score, or depending on what their LACE score is? Do we have the appropriate interventions in place? Do they have care coordination? Are they in a medical home? Can we get them there? And then I would mention that a part of an intervention project that Dr. Howlett already mentioned, we were awarded, starting this last July, the Community-Based Care Transitions Program through our Uninet provider, so we have care coordination there. So the determining factor here is that they are following a certain set of patients, and if those patients aren't being followed by the CCTP program, then hospital care management and coordination would follow up with those patients. And then if they're going from acute care to a post-acute setting, you know, again, do the post-acute setting understand what risks they are? Are they, does the outpatient rehab, a skilled nursing, home care, are they understanding where this patient is in terms of their risk for readmission? We talked about already that we have a nursing home network. They have also expanded that nursing home network to follow all patients going from our hospitals to a skilled nursing facility, and this is part of that CCTP project, and that's a nurse practitioner-led program. Our nursing home, our parish nursing network is also key in the post-acute setting. Long-term care, nurse practitioner oversight. We have just submitted and have talked with CMS at least twice, and we're pretty certain that that this might be a possibility for us. And this really would be a nurse practitioner overseeing all patients that would go to long-term care. And in that long-term care setting, what can we do in long-term care to keep the patients there from having to be hospitalized? You know, because for the older adult that's frail, and in a long-term care setting, sometimes hospitalization can be very rough on them, and can we find a way to keep them in the nursing, in the long-term care setting? And of course, we are also working on our senior nursing network, which would provide more nurse practitioners into assisted livings and into the communities, and to support physician practices of those patients that are frail and at risk for being admitted to the hospital and keeping them at home. So we have quite a few things that we're working in the post-acute setting. So what we know is that the LACE tool was validated. What we don't know is, will the care interventions work? Will they impact the ultimate aim of reducing readmissions? And so that's what we're working on now. There's a lot of literature out there. There's a lot of studies that have already been done. But what we're putting into place, will it work? Will they impact the ultimate aim of reducing our readmissions? And that's what we're kind of studying right now. And I think Jody is submitting to IRB so that we can kind of study this more formally, and that we can publish our results when we see the impact that we are going to make. I just wanted to spend a little bit of time, just as we've already touched on it. This is an absolute wonderful role for nursing, this care coordination. And if you hear him talk about ACOs, if you talk about the transitions of care in the chronic disease management, this really is all around nursing. And the ANA came out with a position statement in June, just this June, reinforcing the nurse's role, that patient family-centered care across the continuum, that nurses, that the benefits of care coordination is reduced ED and improved partnerships of care with patients and families. It has improved the safety of older adults, it improves quality, and improves patient and the family experience. So the care coordination role is something that is, if there's a increase in nursing positions around the country, this is probably it. So we really need to be prepared for that. We need to be able to be good care coordinators, navigators, health coaches, because this is all new roles. Not really new, but they're getting kind of pulled together and formalized roles for nursing. This is their statement was that it's a required part of formal nursing education, and of course the ANA was influential on the final rules of ACOs, because if you read about an ACO, really it's about coordinating care, and that really is the nursing role in the ACOs. Do we have time for questions? Does anybody have any questions? Yes, yes. No, that's just Allegiant Creighton. It is a study that was published, I believe, the first study was in Canada, and this was Walraven's work. And we just looked at it. We thought it was simple. It was something we could put into place. We could understand it. I could understand it. And so we are, I think a lot of other places have used it. I've read other articles of health systems that have put it into place, but this is just our own. So if it works, we'll be glad to publish and share that with others. Yeah. Yeah, Wendell. Right. Wendell's saying is a lot of readmissions due to a patient's own non-compliance with their care and their medications, or even having a primary care provider, because some folks don't really follow up with that. Well, we kind of hate the word non-compliance, because really, have we tried hard enough? Have we explained it? We do something every week. I say we, it's really Beth. Beth Gibbs is here, and she does something every week where she calls it the required clinical reading. And any way we disseminate new policies and information is through that. Well, she did something today in Teach Back, and in the first part, it's unintelligible words. And she said, somebody already said, I think you've got some typos in here. Well, her point was in the teach back is that's what the patient hears. They don't even know what we were talking about. And so a teach back has to be, now Wendell, do you really understand what you're taking? So I think we have to work harder and not accept the fact that maybe someone's non-compliant because they didn't understand. Maybe someone's non-compliant because they don't have the money. Maybe someone's non-compliant because, some people have a distrust of the health system, and so we just have to kind of work through all of those to see if we can't impact it. Wendell, I think that it'll be interesting to see what the studies do show, but basically, as Dr. Howell pointed out, and what we've read is that it really is things like visiting their physician, or their provider. It is making sure that they're managing their medications, and third is making sure they're managing their symptoms. And sometimes they just don't know it. They get those discharge instructions from us, They're hard to figure out. You know, I'm looking at Barb, and she's from Mercy, and they had a patient when they were doing their post-follow-up calls for pneumonia who couldn't afford the medication. So their hospital went together to try to get medication. So there's a lot of reasons that I think we can attack, and we owe it to them and to our community. Yes? Oh, interesting. Again, that points out that we can do a better job of this. The thing that the LACE will provide us is that we will put a lot of resources and interventions in while they're in the hospital. So hopefully it's not the last hour when they're trying to be discharged. They're going to be trying to work through these care interventions the whole time they're here. And we have to do more things that are more understandable in writing. Because I went to the doctor a while back to get some cream for my face because I'm really trying to improve, you know, my looks as I get older, trying to hide some of these wrinkles. And I'm a nurse. And when I got home, I thought, now, what did she say? Where am I supposed to put this cream? How often? And so no written instructions. So I think we have to be mindful. And I think the whole world is open to us in terms of iPads. Think about what we could do about sending people home with information on an iPad, or you know, more interactive information, and connecting them with, now when you go home, go to the website and you can click in anything about heart failure and we can kind of help you. So I think we are just now beginning to realize that we can do a lot more, be more creative, and be what? Yes, Christy. Well, that's part of when we got the CCTP funding from CMS, that innovation project, that's part of it, a Uninet nurse. Now, Uninet is a organization that Allegiant and Creighton have always been working together, so it really truly is an Allegiant-Creighton organization, and it's where the physicians all gather. It's kind of like a physician-hospital organization. And those nurses in there, Christy, actually do follow the patients and connect with them and become their go-to person. The situation for us totally in Allegiant Creighton is that they don't follow all the patients. So those patients, and again, resources, we just couldn't assign one nurse for every single patient of the 33,000 that we have. We would try to identify the high-risk patient with the LACE and then have them followed. So if they're not going to be followed by Uninet, if they're not going to be followed by the nursing home network, if they're not going to be followed by the senior nursing network eventually, or the parish nurses, we would follow them from the hospital through care management and make those calls. So you're right. I mean, that's having a nurse for every patient would be fabulous. Yeah. Right, right. You bring up such a good point, because we have all of you saw that system of care. We have all of those things in place. She's just asking, do we talk to each other? Do we hand off? Do we transition? And a note just came by yesterday, it's so interesting that you say that, is that even in the nursing home network, are the nurse practitioners talking to the providers, talking to the hospital to make sure that the transition is smooth? And in some cases, it's not done as carefully as that. It's done by a referral to the nursing home network, to home care, and then it just kind of happens on paper. But we're trying to do more handoffs, you know, verbal handoffs as well as the written handoffs. Does that answer your question? Right. Yeah. Yeah. Right. Yeah. Right, right. You know, I think that's just a good point, and I think in the beginning when we weren't very busy, we went in and did that. But I think as you know, as resources are available and as numbers increase, it is probably more difficult. But I think that's a good point. I really do think that, you know, handoffs are key. We're learning that within the hospital, within home care, within the nursing home network, that we have to hand off to each other. Even at Allegiant Creighton in the inpatient, the acute setting, is doing a bedside report so that the patient, family, and the care providers, either between shifts or between departments, is happening more frequently, because you're right, we need to have more effective handoffs.